So this is the second module in hygiene, restraints, and safety. In this module, we're going to focus on restraints from chapter 24 on pages 554 and then 568 through 69. So restraints are a method or device used for the purpose of restricting a client's freedom of movement or access to his body with or without his permission. Restraints come in two forms, mechanical and chemical. Mechanical restraints are devices or material or equipment such as a vest or side rails or a wrist restraint that we use to secure someone in a position. Chemical restraints are medication or given to control disruptive behaviors, usually in the form of sedatives or psychotropic agents. So restraints are classified into two categories: medical surgical for the purposes of healing or behavior management. Medical surgical for the purpose of healing, an example of that would be you have your little 90-something-year-old woman who's in the hospital. She has dementia. She keeps pulling at her IV and her tubes and whatnot. So we may put a mitten on her hands to keep her from doing that. That is a medical surgical restraint, and it just keeps her from essentially hurting herself unintentionally. Behavior management, however, is a little different. This is when we need to restrain someone from physically harming themselves or another person intentionally, whether they're cognitively aware of it or not. So oftentimes the behavior management might initially start as a mechanical restraint. We may physically restrain someone to the bed until we can medicate them with a chemical restraint such as a sedative or a psychotropic agent. Things that are not a restraint. A cast or attraction is not a restraint. And if you need to hold someone in a certain position for a procedure or an exam for a very limited time, that is not a restraint. For instance, if you need to hold someone and support them in a fetal position while the physician does a lumbar puncture, then that is not considered a restraint. A restrained person has this natural tendency to struggle and try to get out or remove the restraint. Because of this, they can become entangled or entrapped or trapped in and around the restraint device, usually some kind of strap. With this, we can suffer nerve damage, circulatory impairment, perfusion issues, and even have someone hang themselves or suffocate. So restraints actually cause more harm than good. They consume a lot of time. They actually do not reduce the risk of falls. They can actually cause pressure ulcers and break down the skin if they're not released in a timely manner. Person can lose strength of their muscle tone when they're restrained in the same position for too long. And they also have great emotional consequences, especially if we are younger when that happens. Also can cause contractures. A contracture happens when a muscle is flexed in the same position for prolonged periods of time, and the tendons and the ligaments harden and lose their flexibility and their ability to stretch and contract. So imagine if you pull your arm up and you flex to flex your biceps. If your arm stayed in that position for a long period of time, the ligaments and tendons that help pull the muscles into that position will stiffen and harden, and you can't extend the muscles and the ligaments and tendons out again. Okay, we don't want that. That's not a good thing. So the CDC, along with a bunch of other people, have different requirements about what we have to do in and around restraints. One of the most important is the documentation about the episode. We need to document why we're restraining the person, what happened, what led up to it, how we restrained them, and what they look like in their assessment quite frequently after that. Most of these places also require one-on-one viewing of the client at all times. So they basically need a sitter to sit there and watch them while they're in seclusion. Okay. They encourage the use of bed alarms so that the person tries to get out of bed. There's an alarm to let you know that. Restraints require a prescription or an order in order for us to use them. However, if we are in an emergent situation, we can implement restraints, but then we have to contact the healthcare provider to provide us with a prescription or an order to use them. And this prescription has to be renewed every 24 hours. So the healthcare provider can't write an order that says restrain Mrs. Smith as needed for the next 7 days. Every single 24-hour period, the order has to be written for what type of restraint and the specifics for doing so. Once that happens, we're responsible for an ongoing assessment of the skin and everything related to the restraint, from pulses and sensation to what the skin condition is. Is it wet? Is it dry? We also, if the person is restrained physically into the bed, need to address food, toileting, bathing, those kinds of things as well. So standard bedside rails can be considered a restraint. Most beds have 4 rails, 2 on the top part at the head and chest, and 2 at the bottom from the waist and the ankles down. Whenever all 4 rails are up, our governing bodies have decided that that is an actual restraint. So for all 4 bed rails to be up, we have to have an order for that. That has to be renewed every 24 hours. The person has to have a sitter. We have to document just as though they were strapped down to a bed. Okay, so a client may want both the upper rails up to help push themselves up in bed and manipulate. That's fine, as long as all 4 rails are not up. So there are 2 photos in the slide here for you to look at. The one on the bottom left shows a client who is in 5-point restraints. The 5 points are both ankles or feet, both wrists or hands, and that black strap that's going across his waist. Okay, so he is strapped down or restrained at 5 points. He can't hit us with his leg or his arms. He can't kick us with his feet. And he's strapped at the waist, so he cannot attempt to get out of bed. What's really important here is, 1, how they're put on so that they're not too tight. And 2, you see the straps are attached to the frame of the bed. You never attach the straps or the restraints to a movable part of the bed. Okay, that's for the patient's safety. You don't attach them to side rails because as they go up and down, we can injure the patient. Also, I have seen a patient one time where the nurse aide restrained the ankle. See that hole or that little square hole in the footboard of the bed? She used that space to secure the restraint. Well, the patient was able to manipulate the headboard loose from the bed and managed to start kicking around. So we had this headboard swinging around in the room, which became very dangerous. So in the next picture, we have what appears to be a little old man, because it looks like it, and there's a urinal hanging at the bedside, who looks like he's attempting to get out of bed. What's interesting here is if you look at the right side of this patient's bed, you see that there are no side rails up, but there are 2 side rails up on the left side of the bed. As you can see, he's kind of caught between the 2 of them. The good thing is I don't see any kind of restraints that he can use to hang himself with, but this is still a pretty difficult predicament to get out of, and he can injure himself in many ways. So here are a couple of pictures of some restraints that you might see. The top left is a wrist restraint. That's sort of a foamy feel. It's very soft. Uses Velcro and a little metal clip and tongue to catch. And then it has the straps that would tie to the bed frame. Okay. The one in the middle on the top is a mitten that I talked about earlier. What you're seeing is the fluffy, puffy side. If you turned this person's arm over, you would see mesh, and you would see the anterior part of the person's hand where the nails and the knuckles are. Okay, what's really important here is that when you put the person's hand in the mitten, is that their palm is down on the fluffy side, on the padded side. Otherwise, they're still able to move their fingers with the mesh and grab things. If you also notice, the strap to this mitt is not necessarily attached to it. There's a way to do that so that you can attach it to the bed if you need to, but you don't have to. Either way, if you put this mitten on, it's considered a restraint. Okay? In the top right-hand corner, this young man looks really happy to be in his little restraint vest. The biggest mistake people make when putting on a vest restraint is they try to put the straps on the person's back or along the mattress. The straps go in the front, okay? And as you see, it goes down the side of the bed and should be tied to the frame of the bed. If you're not getting it, the frame of the bed. That is a test question, people. Okay, the bottom left corner, I don't like this photo, but it's in here. This is a photo similar to what you saw in the previous photo. That's going to keep someone in the bed. It's around the waist, and then the straps are tied to the bed frame. But it's not going to do this person any good because their hands are free and they can undo this. So what's important here is that they're not able to undo the belt to get it off. Okay, and then the last picture is a net bed. And a net bed is really cool because it's this frame that fits over a bed and is mesh and has a zipper that the person gets in, that you can get in and out of the bed with. They're really cool, but our patients are also creative and figure ways to get out of them. These are really good with small children. so that you don't have to physically restrain them and they can't go anywhere. But like I said, they get creative and they find ways to get out of here. So here we go. Only tie to the bed frame. Never tie this to the side rails or a moving part. You should also use a slip knot, very similar to what you see here in Form A. And you can see how it looks down in Form B. That's so that if you need to release the restraints, you can do so very easily without creating a knot.